Okay, we'll get started. Today's webinar is on laser therapy for meniscal tears of the knee. And my name is Dr. David Kunashko. I'm the medical director at BioFlex Laser Therapy. I tend to do two types of webinars on a monthly basis. These are complementary. I always do one on professional equipment and more geared towards healthcare professionals. That's what today is like, although anyone can watch. But my discussion around how to use the equipment revolves around using the professional equipment. And then I also do a webinar every month using our home devices, typically the P120 or P180, which are home-based photobiomodulation devices. And the next one I have for that is in a couple of weeks, and again on the knee, but more just for knee stiffness related to osteoarthritis, that kind of thing, where people at home would probably be using that kind of equipment. These webinars are always recorded and then eventually they're uploaded onto our website. So if you miss it or you want to watch in the future or future webinars, they are eventually put onto our website. Of course, watching live gives you the opportunity to ask questions, which is part of the learning process. So meniscal tears of the knee, obviously, it's a pretty common condition, both in young, but especially as the patient base gets older into 40s, 50s, and 60s and beyond, you start to get degenerative tearing. And this leads to more sort of degenerative fraying in the menisci, and this leads to small tears. They become problematic because they tend to be a source of pain and discomfort and stiffness, as well as if they get fairly large or significant, then actually impede mobility of the knee as well too. So this is why it's really important to, number one, have a good diagnosis to see what's going on with your patient, and then to see if they're a candidate for laser therapy over surgery, for example. I'm going to talk a lot about that today, along with the review of the anatomy of the meniscus and how and why it's so challenging to heal as a tissue, and then specifically about meniscal tears, the epidemiology, etiology, that kind of thing, and the symptoms that you would see in your patients, and then why you would use photobiomodulation therapy to help these kinds of conditions heal a little bit faster and help with symptomatic relief. There's a bit of research on this topic that's been published, so I'll share that as well. And then specifically, I'll talk about the protocols, how you want to customize the protocols, and some approaches using our equipment for these kinds of injuries. And there's always time for Q&A. If you have a question, type it into the Q&A box. There is a chat box. You can let me know in the chat box where you're from. If you have the equipment, you're just interested for whatever reason. That's always fun to see. So let me know in the chat box if you're feeling up to that. And if you have a question about what I'm presenting, then certainly ask that in the Q&A box, and I'll get to those questions at the end of today's session. I think I have to sneeze, so let's see how I manage here. Hang on one second. No, that was a false alarm. Okay. So let's get started. All right. So, of course, we have the knee joint. Everyone knows what the knee joint consists of. You have your femur, your tibia, and fibula. Then you have the articulating surfaces between the tibia and the femur, of course, between the patella and the femoral condyles as well. Obviously, today we're interested in the hyaline or the meniscal cartilage, which is, of course, a cushioning protective C-shaped cartilage medially and laterally. You can see here on the far right, it has a nice view of it. And of course, you can see it's cushioning in between. And with time, with injuries, all that kind of stuff, it wears and tears and it starts to degrade. And of course, in sports, especially if you plant your foot and you twist your knee, there's certain mechanisms that will lead to potentially tearing of the menisci. I personally play squash, and both my knees have torn menisci. So I can definitely relate to this condition. And yes, I use laser therapy, and no, I have not had surgery. I don't think I need surgery, but it certainly helps having laser therapy. If you've raised your hand, I'm not sure if you've done that inadvertently or not. If you have a question, then just type it into the Q&A box. I'd appreciate that. Okay, so the hyaline, or sorry, the meniscal cartilage consists of, it's a fibrous type of cartilage. It rests and is actually attached physically, as you know, to the tibial plateaus. You can see here the lateral meniscus and the medial meniscus, right? So this is a superior view with the femoral condyles removed, and you can actually see the C-shaped curve. It's actually very thin on the inner margin, and it thickens as you go out laterally. So to the periphery margin of the cartilage, it gets much thicker. And there's a bunch of ligaments that holds it into place, of course. As I mentioned earlier, the meniscal cartilage main role is in cushioning and lubrication. It helps with that as well as shock absorption. So, you know, your knee joint load, a lot of that is being bared, I guess, I don't know, through these meniscal cartilage. They transmit central compressive loads out towards the periphery, which then decrease contact pressure on the articular cartilage. So here's the thing. If you have your meniscal cartilage removed, you increase the contact pressure on the hyaline cartilage. And guess what? You have earlier onset of degenerative changes of the hyaline cartilage, in other words, arthritis. So anyone that has had their menisci removed or partially removed, then you're setting up for a earlier onset of arthritis. So that's not a good scenario, but sometimes that's necessary if they doesn't heal or if it's just not surgically possible to repair it. And oftentimes it needs to be snipped out or whatever, and this leads to less cushioning of the joint. So bear that in mind if you have a patient looking at surgery or yourself or what have you. That's important to understand. What's also super important to understand, again, if you have any questions, I don't mind answering them, but please ask in the Q&A box. So the inner 2/3 of the menisci essentially are avascular, meaning no direct blood supply. No direct blood supply equals very poor healing. So that is why when tears happen in the inner portion of the meniscal cartilage, it's super slow to heal. And innervation-wise, there's really little innervation of the menisci, just a little bit in the cartilage. The outer third has some vascularity, but of course, as we get older, there's less and less of that. This area is called the red zone. So for obvious reasons, because there's blood supply. So what's interesting is the red zone when you're born is the entire cartilage because it's so small and there's actually blood supply. But as you get older, from 18 months up to 18 years, you can see the red zone is where the squiggles are. You can see the red zone starting to decrease. And the white zone, remember, white zone has no blood supply, starts to increase as well. And over 50, the actual red zone is now significantly less. Instead of the outer third, it's probably the outer quarter or whatever. So there's really not a lot of blood supply to help heal the potential tears in your patient. So again, this is just another view showing the little dots represent blood supply. And you can see here that the blood supply is really limited on the inner portion of the menisci. And this is where a lot of tears happen. So that's why they're pretty challenging to heal. So if you actually cut into the meniscal cartilage, you'll see there's different kinds of cells. There are these chondrocyte-like cells. These are basically produce collagen and help the meniscus repair. Then there are fibroblast-like cells. These also, chondrocytes are sort of cartilage-like cells, and fibroblasts like cells produce collagen as well. You can see there are some blood vessels, and you can see that, you know, there's this white region, inner portion, and the outer portion is the red region. Now, if we look at the two menisci, there's a lateral and a medial. You know, it's funny, all my tears are, no, I have like 4 tears. Most of them are lateral for whatever reason. but most of the time it's medial tears, and I'll talk about that shortly, which I'm sure you know. Lateral meniscus is not really attached firmly to the tibia as well as the medial meniscus, so it can move around more, which is good because when you tension it, like when you plant your foot and you twist your knee or whatever, it's less likely to tear. Whereas a medial meniscus, tear meaning being injured, and then the medial meniscus is actually a lot more stable, less movement. So then when it's under pressure, like twisting or torque, it can actually tear much more readily. So it's stabilized by the MCL, a transverse ligament, meniscal femoral ligaments, as well as direct attachments of the horns, which are the sort of ends of the menisci, directly to the tibial plateau itself. Now let's talk a little bit about the causes of menisci. I think you probably are aware that a lot of these do occur with different sporting activities. Plant and twist your foot. So soccer, football, basketball, squash, tennis, pickleball. And did you know I heard about this new game. It's called Padel or Paddle. Have you heard about this? It's Padel. It's a combination. I think it's popular in like Europe or the UK or something. And so it's a combination of squash and pickleball. So you can imagine, I don't play pickleball, but you know what it looks like, a little bit the paddle thing, and then you have the ball. But the ball is a bit bouncier. And on the back of the court, there's like a clear or a wall where the ball can bounce off and remains in play like a squash court. So instead of pickleball where you try and contain it in the court, with Padel, it actually can bounce off and then you retrieve it. It's actually more of a strategy game kind of thing. Anyway, it looked kind of interesting, but I don't think there's many Padel courts around. One of the most common injuries, obviously in orthopedic sports medicine, they say in sports anyhow, it's about 24 per 100,000 incidence level. It also occurs in obviously non-sporting injuries, almost 40%. And then some people coming into this go, I don't know, I got this. I have no idea how it happened. And usually you see that where the menisci are kind of degenerated or worn, and they could just be doing regular stuff and, and planting their foot and they're not quite sure. And then next thing you know, they have some pain in their knee. Seems to be more common in males compared to females. I'm not really sure why that is. Maybe, I don't know if more males play sports or not, but I don't know. More males are dumber, so they pretend to do stuff in sports that are probably as smart as females. So there's that too. Okay, and then there are most of the tears occur in the medial meniscus. That's about 2/3 of the cases. And an ascent from a squat is a common mechanism of injury, not widely described or emphasized. So like you tend to think of things like CrossFit, those kinds of exercises, they can oftentimes lead to these injuries as well. So if you break it down age group wise, you can see that a lot of tears occur in sort of later years, 65 plus. There's a big segment in 45 to 64 and a much smaller segment in the younger population, because usually for those, it really only happens through trauma, like through sports. Whereas as you get older, like you bend over, you hurt your back kind of scenario, like you're just walking or hiking, and next thing you know, you torn your meniscus, right? Unfortunately, that's just how our bodies work. So excessive force applied to a normal meniscus or a normal force acting on a degenerative meniscus is really how these things occur. The most common mechanism, as I've already mentioned a few times, is a twisting injury on a semi-flexed limb through a weight-bearing knee. So, you planted your foot, it's flex, and then you go to turn or twist without moving your foot. It is commonly associated with other injuries. So oftentimes when an MCL is torn or an ACL is torn, you'll tend to see a meniscus, a medial meniscus torn as well, especially in these kind of sporting injuries. There's different types or classifications of tears. You can see a discussion of that on this chart. You have horizontal, you have radial tears, degenerative tears where you see it's broken down and then it can actually lead to larger tears, just like kind of arthritis. Here's an oblique tear and a vertical longitudinal tear. So these are all different types of tearing. The meniscus eventually, as I mentioned, can deteriorate over time. And this is a really big factor in that older age group, 65 plus, 50 plus, where you start to see and predisposed to traumatic tears. And again, when I say traumatic, it could be something as simple as just hiking or walking or doing stuff like that. And, you just don't pay attention. Next thing you know, you cause tears. Radial tears, these are really short little tears. They extend from the medial rim towards the lateral rim of the meniscus. So you can see here, it starts in the inner portion and kind of goes inward. That's a radial tear. Small radial tears can be healed. Large, big, open gapped tears might have a tough time healing because the gap is so big. The only real way to diagnose this is through an MRI or imaging, right? Obviously not an X-ray, but through a good MRI, and you can actually see what kind of tear. I personally, with my knees, I demanded an MRI because I want to know what kind of tears they were. Then I could kind of tell what my next step would be, kind of scenario. Then we have vertical longitudinal tears. They extend sort of along the length of the meniscus. Sometimes they can kind of push apart as well too. These depending on the size of them, they can be healed as well, especially if it's closer to the red zone. If it's in the white zone, that's a little bit tougher. And then there's a dreaded bucket handle tear. This is a pretty common tear. It's a vertical longitudinal tear that goes through the full depth of the meniscus. So it separates off. And these suckers are very problematic because they can actually cause or impede movement. This is where patients say their knee locks, excruciating pain, and it takes a long time for it to start to move again. Like stuff like that. Yeah, then you're looking at probably surgery. And oftentimes they do a meniscectomy where they remove the meniscus or partial meniscectomy. And this will, well, it solves the short-term problem, but creates long-term problems, you might say. I don't think they have artificial meniscus, like they haven't really developed them that is going to work great yet. So maybe eventually they'll figure that one out. It would be nice though. But I'm not up to my orthopedic surgeon stuff. So well, I don't know, maybe they're starting to do that. I should look that up. So then you have a horizontal split in the body of the meniscus. This is usually called a horizontal cleavage tear. That's a big problem right there. And then you have a flap tear. Flap tears are also problematic because they can sort of go up, right, into the joint line. And they can cause and sort of block movement of the knee joint as well. That's where you again get the patient saying it locks, the knee locks, right? So, when you're doing your examination, you're palpating and you're feeling and seeing if it locks or, what's going on there. But really, to be honest, you're going to have an MRI to get a proper diagnosis. Probably you're going to be right if it's a tear or not, but the type of tear, you're going to have imaging. So symptoms, you can imagine there's going to be some tenderness, especially along the joint line where you push in. So on the medial joint line or lateral joint line, when you push in, there's usually tenderness. That's if the tear is sort of, within palpable kind of ability. Sometimes they're so deep that's not going to really be painful. Usually you do get some effusion inside the joints, a bit of swelling, especially after activity. So there may be no pain or swelling at all. As I mentioned, if the inner portion of the meniscus is damaged because really there's no nerve supply there, and you can't really feel pain there. Symptoms are aggravated by flexing and loading of the knees, so think like squatting and kneeling. And I mentioned obviously clicking, locking, giving way. These are all common symptoms of meniscal tears as well. Treatment-wise, you can imagine surgery is pretty common. So I don't know, like the stats are over 1 million patients a year in the US. Divide that by 10 in Canada, you got 100,000 people undergoing meniscectomies or partial meniscectomies or some kind of surgery procedure to help meniscal tears. Total meniscectomy results in about 50% reduction in the contact area. So you're losing a lot of shock absorption. And they say it can lose up to 20+% of shock absorption ability of the knee. So currently, surgical repair techniques are really only effective in treating the lesions in the peripheral vascularized region of the meniscus. So in other words, they're not going to suture it up if it's in the white zone where there's limited ability of that cartilage to repair. I kind of argue that because I think that if you were to use photobiomodulation and have them like sutured up, or they have techniques where they can put them together, then there's, I think, a greater chance that the meniscus can actually heal to some degree, but it's not great. The most common surgery is the partial meniscectomy. Again, this is going to commonly result in progressive development of osteoarthritis, probably going to take 5-10 years to manifest. Tears that are stable and do not cause significant mechanical symptoms, in my humble opinion, shouldn't undergo the knife. Like, it just doesn't make sense because you're going to lead to have more problems like arthritis, right? If you can tolerate the pain and do other things to manage it, I would do that. So when I say other things to manage it, laser therapy, maybe chondroitin sulfate, glucosamine, maybe PRP, maybe some stem cells. Like, there's a bunch of options one can do to help. Tears that are unstable, then, you're looking at perhaps surgery. And this is where you get locking, really unstable knees. The meniscus is all over the place. You kind of need to have it removed. It's unfortunate, but that's the way it goes. Now, why would you do photobiomodulation? One of the biggest reasons is it can increase microcirculation and increase angiogenesis and neovascularization. So this is essentially if you were to irradiate the menisci of the knee, that light will increase the production of new capillaries and branches of capillaries and increase the red zone. Now, I'm talking over a period of time. When you do this, you have a great ability to heal. The more vascular the meniscus, the greater the chance that it can heal to some degree. So angiogenesis, just so you're aware, is a process by which new blood vessels grow from pre-existing blood vessels. And it's really critical for any injury, wound healing, that kind of thing. Obviously going to supply nutrients for newly formed tissue, whereas neovascularization is formation of new functional microvascular networks with obviously more red blood cell perfusion. Another mechanism of how photobiomodulation might help with meniscal tears is through the release of nitric oxide. Nitric oxide is both released intracellularly from cells that are exposed, that are inflamed and exposed to light therapy. There's also some research to suggest that nitric oxide that is bound to red blood cells can also be unbound, basically, or disassociated from red blood cells and go into the bloodstream. And then from there, that nitric oxide will basically trigger soluble guanylyl cyclase, because I know you need to know that, SGC. This is the nitric oxide receptor in smooth muscle of capillaries and small blood vessels, and this results in vasodilation. So essentially, by promoting blood flow, you're going to promote healing. And of course, you're going to reduce edema and help with nutrition of the joint. Okay, so that's another reason why you would do photobiomodulation. So since red blood cells are continuously delivering blood to an area, the natural supply of nitric oxide that can be released from each new red blood cell that passes under the light source and is exposed to photons of appropriate wavelengths. So in other words, the longer you treat with the dual array over the area, the more nitric oxide that's going to be released, the greater the vasodilation. Half-life of nitric oxide is only a few seconds, so its effect is very short. But if you keep doing it over, 10, 12 minutes, you'll have a greater chance of getting more circulation. So that's kind of why we recommend increasing the treatment time over the meniscus tear. Another reason for using photobiomodulation that kind of makes sense is that it can interact with these fibroblast-like cells and chondrocyte-like cells, and it can increase their metabolism to produce more collagen and more matrix and help with healing. So that's really the name of the game. And of course, you're going to get some analgesic effect with photobiomodulation. We know that substance P, prostaglandins, bradykinins, COX-2 levels, they all go down when exposed to light, and these are all cause pain. So when these go down, you have less pain. And I've mentioned before about some analgesic effects of photobiomodulation where it can actually temporarily block transmission of pain in A delta and C fibers. This is very helpful in temporarily reducing pain. It's also been associated with an increase in endorphins and enkephalins, so your own body's natural painkillers as well. A little bit of research. This paper was published entitled Low-Level Laser Therapy in Meniscal Pathology. It was a double-blinded placebo-controlled study, 64 patients. They were all diagnosed with grade 3 tears, and they had treatment 2 times per week for 3 weeks, and then once per week for another 3 weeks. So they had a fair amount of treatment, and that's really important to understand that when you're treating a meniscal tear, it's not just a week or two, it's 4 to 8 weeks at least, maybe longer of treatment. So they did imaging and they showed where the tears were on these patients. So they were diagnosed. And then they were randomly assigned either, laser group or placebo group. What's interesting is they used different frequencies. They used 2400 hertz, 700 hertz. They kind of said 2400 hertz was anti-inflammatory and 7 hertz was healing. That's the first time I've ever seen that. I don't know. They must have a reason for saying that, but it's interesting. You can try it. You can customize the protocol and set it for those frequencies if you want to try that as well. They used about 2.5, 3 joules. That's not a lot, by the way, of infrared wavelength. That's about, at 100% power, that's only a few seconds of the laser probe, the LDI 200. I would set the probe at like 40, 50% and hold for at least 10 seconds, maybe a little bit longer to achieve at least 3, 4 joules. I personally would go double that for the number of joules. So they looked at subjective knee pain. They used visual analog scale 0 to 100. They also completed the Leishholm knee scoring system, which is a specific questionnaire. And so, the maximum score possible is 100. So you want a higher score as opposed to a lower score. So for example, I have no limp when I walk, that's 5. I have a severe and constant limp, that's 0. So the lower your score, the worse you are. Okay, so pay attention to that when I show you the results. So at the end of the trial, the placebo group was given a choice of either continuing laser therapy or consulting with an orthopedic surgeon. And then they did follow-up groups 6 and 12 months later. And what they noted was that none of the patients in the study group receiving laser therapy underwent surgery, arthroscopy, or had a new MRI. So it helped. So treatment, they concluded that treatment with laser therapy was associated with a significant decrease of symptoms compared to the placebo group. It should be considered with patients with meniscal tears who do not wish to undergo surgery. Well, I think that's probably everyone, right? Okay, so this is what they showed. This is visual analog scale. Remember, it's 0 to 100. They started at 74 for the group that received laser therapy. After the treatment regime, it went down to 26. After 6 months, it was at 25 and 27 after a year. In the placebo group, it started at 74. It went down because you always get a placebo reaction to 58. And guess what? After 6 months, they were back at square one at 75. A year later, 76. So they were still, not feeling great. And then the Leishholm score, I guess Swedish, started at 77 for the laser group. And remember, the higher the better. Then went up to 82 and kind of stayed at around 82 for a year. Whereas in the placebo group, started at 77, went to 79, but then went down. They got worse over time, right? Because you kind of expect that. So it just goes to show you that if you're not doing laser therapy for meniscal tears, why not? You should be, the evidence is there for sure. Okay, so of course, I need to give you some tips on treating these kinds of conditions with BioFlex equipment. You want to increase the treatment time over the affected area. If it's a medial meniscal tear, which usually it is, increase the time from 6 minutes to maybe 8 minutes of red and 8 minutes of infrared. 7 or 8 minutes is good. You want to make sure that the knee is in a loose or open pack position, about 25 degrees of flexion when you're treating, not a closed pack. And for the laser probe, initially set it for about 40% power. You can slowly increase that power. You're going to be holding it for at least 5 seconds, 10 seconds, depending on where that tear is. If it's really deep, I would hold it for longer. You can use the red laser probe. That comes in handy. It's not going to do anything for the meniscus, but it's going to help with pain. So if you have a red laser probe or you don't have if you have a red laser probe, use it. If you don't have one, the reason why you'd want it is that although it's superficial, it does help concentrate light in the superficial nociceptors and helps kind of block pain. It's quite effective at doing that. So palpation-wise, you need to know where the joint line is. I say this facetiously because I know you all know where it is, but your assistant or someone doing the treatment in your clinic may not be quite as adept as you. So I would mark it, use a couple little dots or whatever. Make sure you mark the joint line and where that meniscus is, because if they're placing the laser on the femoral condyle or the tibial plateau, right, then you're wasting your energy. You really are. You need to have it on the joint line itself. Okay, so this is what it would look like if you're treating the medial meniscus area, right? The middle of the dual array is placed in the middle of the joint line, right? And secure it with the knee in 25 degrees flexion. Even if it's a lateral meniscal tear, I would still recommend, or sorry, even if it's a medial meniscal tear, I still recommend a lateral placement. Okay. The reason for that is that whole systemic effect, right? And the anti-inflammatory effect and the vasodilation effect around the knee joint. And then I recommend a popliteal or posterior position. This is more so for treating the vascular network that supplies the knee, right? So the blood vessels, the popliteal arteries, all the blood vessels, they go into the knee and are supplying that red zone in your meniscus. So the more light that's going into blood, the more that blood that's going to be affected by light and can actually trigger an anti-inflammatory response and a healing response inside of the meniscus. Protocol-wise, for the first several, maybe 6 sessions, let's say we're treating the left knee and we're treating the medial meniscus, we're going to treat the medial meniscus 8 minutes, red, continuous wave. Then we're going to treat 8 minutes of near infrared, 50 hertz, 70% duty cycle. And then we'll treat the lateral knee, 6 minutes red. You can even go down to 5 minutes. 5 or 6 minutes on the lateral side, 50, 70, and then the popliteal region, same as the lateral region. Laser probe, a continuous wave, 42% power is roughly 75 milliwatts. And you're going to treat along the joint line, anywhere where it's tender, trigger points, swelling areas, that kind of thing, up to 9 minutes total time, 10, 15 seconds per point. If you have the red probe, you can also use that at 100%. Then over time, 3-6 sessions in, if the patient is not responding as well or is slow to respond or plateauing, you can then start to increase the frequency and duty cycle of the infrared and maybe even increase the power of your laser probe. We can do it in smaller increments as well, maybe go from 42% to maybe I don't know, 60 or 70%, and then 80, 90%, and 100%. I personally like a little bit lower power and hold it for longer. I know it's kind of a pain because you're treating the patient for longer, but the treatment time is actually more beneficial than more power because you have longer time that those photons are going in. The depth of penetration is really based on the wavelength, not the power, right? So the longer you hold, the more light that can kind of go deeper into the meniscus. And eventually you can kind of increase even more, go up to 90% duty cycle, maybe even pulse the red a little bit, change that up a bit. So again, these are all just suggestions that you can try when you're treating a meniscus. If you don't have a diagnosis, like if you don't have an MRI, then it's hard to give a prognosis. But in general, if you think it's a partial tear, you're going to tell your patient it's going to take months to really significantly get better. And then after a month of treatment, I'm feeling they should be at least 20 to 50% better, sometimes more, but in that range, okay? So a few other tips: ensure there's good skin contact with the laser probe and the treatment array. I've mentioned about holding the probe anywhere from 5-10 seconds, maybe even a little bit longer. You can slowly increase the time that you would hold the laser probe on each spot if the patient's a little bit slow to respond as well. And then remember, you want to keep the knee in an open pack position that's roughly 25, 30 degrees of flexion. I would spend more of your time with the laser on the medial joint line if it's a medial tear. If it's a lateral tear, then laterally. And remember, it could be a anterior or a posterior tear, medial or lateral. So you need to know where it is, right? And usually that's based on either palpation or imaging. So if it's a posterior horn medial tear, then you should be mostly on the joint line in the sort of the mid to posterior region of the joint line, if you can envision that. And don't forget to treat the posterior knee compartment because lots of blood there. Next webinar in a couple of weeks for personal therapy systems. This is treating stiff knees, more related to like arthritis and, you know, when us old folks get stiff knees. And then I'm going to do a webinar, a professional webinar on treating multiple sclerosis, which I've never done yet. So, I mean, I've treated, I'm just saying I haven't done a webinar on. And then I'm going to do one on using personal systems for treating, recovering from after your workout, training, that kind of stuff to help with that kind of pain scenario. If you have any questions, you can email me. If I don't respond to an email, it's not because I don't want to, it's because sometimes I get a lot of emails and sometimes they get buried, or I don't know, I just miss them. Just give me a little, if I don't respond within 24 hours or so, then just give a little quick follow-up and I'll make sure I do answer that. So Aman, you wanted to chat after the webinar. Yeah, let's try and do that. You can give me a call. If you have one of my emails, you'll have my phone number for that, so that's no problem. How quick is revascularization? Not quick. Weeks is what I would say. And that's slow. I mean, it occurs slowly. If a client age 32 is diagnosed with a partial tear and osteochondroma about 1 by 1 centimeter, is it safe to proceed with BioFlex laser therapy? So if it's a osteochondroma, I believe is not carcinogenic, right? Like if it's a tumor that's not a cancer, then you can treat. If it's an actual cancer, then you can't treat it. Sorry, I'm just not quite aware where that falls. But if it's an actual tumor that's growing, you don't want to treat it. But if it's a benign tumor, you know, like a lipoma or whatever, that's perfectly fine to treat over that area. Let's see here. Okay. I think that's it. Thanks very much for joining in. Hopefully it was informative, and maybe you can make the next webinar. Any questions, follow up, you can email me, david@bioflexlaser.com. And if you're interested in the equipment, then you can contact one of our account executives, or be happy to chat a bit about our equipment as well. Take care, everyone. Have a great day. See you next time.